All right. Welcome back to NeuroClarity, the podcast that brings you crisp, clear, and clinical neurology one high-yield episode at a time. My name is Nori Victor, and I am your host. And today we are diving into four essential neurovascular scenarios, each with life-saving implications and brain teasing depth. Our cases are derived from Ching and Cheng's comprehensive review of clinical neurology. We are currently in chapter 2, and we are doing questions 66, 67, 68, and 69. So, whether you're walking to your rounds or you're just reviewing for the boards, we've got you. That being said, let's get started. Question 66. Which of the following is the most common location to harbor an intracranial saccular aneurysm? A. Basilar apex, that is the top of the basilar. B. Posterior inferior cerebellar artery origin. C. Anterior communicating artery. D. Middle cerebral artery bifurcation. And E. Pericallosal artery. What do you think? Well, let me break it to you. The answer is C. Anterior communicating artery. Saccular or berry aneurysms are acquired lesions and they are found in about 3.2% of the population. That is, for every 100 persons, 3 actually have a berry aneurysm. They are often silent but they are dangerous, with rupture being the most common cause of non-traumatic subarachnoid hemorrhage. The anterior communicating artery is the most common site and it's involved in about 30% of cases, and following that we have the posterior communicating artery which accounts for 25%, the middle cerebral artery bifurcation which accounts for 20%, the internal carotid artery bifurcation which accounts for 7.5%, the basilar apex which accounts for 7%, the pericallosal artery which accounts for 4%, and the posterior inferior cerebellar artery which accounts for 3%. These aneurysms are often found at arterial bifurcations where turbulent blood flow stresses the wall, and patients may have multiple aneurysms, especially if there is a family history or connective tissue disease. So, that being said, like we said, anterior communicating artery, which accounts for 30% of all cases, takes a beat. Our answer is C. Next question. Question 67. A 56-year-old man was involved in a fight and suffered facial trauma with a break. He later noticed that he could not open his left eye and developed periorbital swelling that would cause progressively worse by the next day. He also reported hearing a roaring machine sound in his head with each heartbeat. On examination, prominent periorbital swelling was noticed with chemosis, proptosis, and ophthalmoplegia of the left eye. Intraocular pressure was increased with significant reduced vision. Brain CT showed no hemorrhage. Angiographic images during treatment of this lesion are shown in figure 2.21. Let us take a look at it. Which of the following is correct regarding this lesion? A. This patient has a direct carotid-cavernous fistula. B. This is an arteriovenous malformation in the medial temporal lobe. C. Ocular symptoms and cranial nerve palsies do not improve despite treatment. D. Open surgical treatment is the best option for this lesion. And E. The feeders are external carotid branches. What do you think? Let's paint the picture. After blunt facial trauma, this patient develops pulsatile proptosis, chemosis, that is conjunctival swelling, ophthalmoplegia, which is impaired eye movement, roaring tinnitus, which are bruised that are synchronous with pulse, and increased intraocular pressure plus vision loss. This is the classical pentad of symptoms from a direct high flow carotid-cavernous fistula, which is a subtype of dural AVFs fistula. Let's get what's happening. The cavernous segment of the internal carotid artery has torn and arterial blood is shunting directly into the cavernous sinus. This increases the venous pressure in structures that drains the orbit, especially the superior ophthalmic vein, which becomes dilated and tortuous. Now, cranial nerves number 3, 4, V1 and V2, alongside with 6, all of which course through the cavernous sinus, become compressed. What do you see on imaging? On digital subtraction angiography, you will see early filling of the cavernous sinus in arterial phase, dilated superior ophthalmic vein, and white-out appearance of venous sinuses during arterial injection. There are two types of carotid-cavernous fistulas and they include the direct and indirect types. The direct types are high flow, typically traumatic as a result of a tear in the internal carotid artery. They are dramatic and they have an acute presentation. The indirect type, on the other hand, are low flow, often spontaneous in older women, and they are insidious in presentation. And in fact, the indirect types are fed by small dural branches from the internal carotid artery or the external carotid artery. How do we manage? Management is via endovascular embolization, which is the gold standard. There are two approaches: the transarterial, which is directly through the internal carotid artery tear, and the transvenous, which is via the inferior petrosal sinus or the superior ophthalmic vein. The goal is to obliterate the shunt while preserving the internal carotid artery patency. What are our outcomes? Well, we tend to see that the chemosis and proptosis improve almost immediately. The cranial nerve pulses may take days to weeks to recover, and visual recovery depends on ischemic damage duration. So, back to our question. Our answer is A. Direct carotid-cavernous fistula. Next question. Question 68. A 45-year-old woman presented with pulsatile tinnitus and was diagnosed with cranial dural AVFs fistula. Which of the following is correct regarding this condition? A. Drainage to a dural venous sinus is seen in less than 1% of patients. B. Endovascular embolization does not play a role in the treatment of dural arteriovenous fistulas. C. These lesions have a parenchyma nidus and pia arterial supply. D. These lesions are always congenital. And E. Cortical venous drainage is associated with higher risks of hemorrhage. What do you think? Well, our answer is E. Cortical venous drainage increases hemorrhage risks. Let's talk about cranial dural arteriovenous fistulas. Now, these are abnormal direct shunts between meningeal arteries and dural venous sinuses or leptomeningeal veins, and they occur without a nidus, and that makes them different from arteriovenous malformation, the absence of a nidus. They are believed to be acquired, and they are due to venous sinus thrombosis, head trauma, surgery, or infection. The venous hypertension from sinus occlusion may trigger angiogenesis, which leads to arteriovenous shunting. Now, symptoms depends on venous drainage. For benign lesions, which are generally type 1, they drain into dural sinuses with arteriograde flow, which causes pulsatile tinnitus and headaches. For the aggressive lesions, which are types 2 and 3, these have retrograde cortical venous drainage, and they have higher risks of intracranial hemorrhage, venous infarct, seizures, and focal neurological deficits. Now we've talked about type 1, type 2, and type 3, and this is something we call the Brodin's classification, which stratifies these lesions based on their hemorrhage risks. Type 1 basically has arterial supply that drains into dural sinuses, and these are actually the normal drainage. Type 2 is the arterial supply which drains to both the dural sinus plus retrograde cortical veins. And type 3, this drains directly into cortical veins. How do we make our diagnosis? Well, diagnosis is by MRI or MRA, which may show dilated venous structures or flow voids. CT angio can also suggest abnormal flow patterns, but the gold standard test is the DSA, a digital subtraction angiography, which helps to evaluate arterial supply and venous drainage patterns in real time. Treatment is via endovascular embolization, and this can be done in two ways: the transarterial approach and the transvenous approach. Transarterial approach is through the meningeal arteries, example the middle meningeal artery, and transvenous approach is through the sinus or cortical veins if needed. You can also use embolic agents, which includes glues and coils. Surgery is reserved for inaccessible or embolization resistant lesions, and radiosurgery is employed in small, deep, or non emergent dural arteriovenous fistulas. The prognosis depends on whether or not we have cortical drainage. Without cortical drainage, you can do frequent monitoring, and with cortical venous reflux, this has a higher risk of hemorrhage and needs immediate intervention. So, back to our question. Our answer is option E. Cortical venous drainage is associated with higher risks of hemorrhage. Why are other options not correct? Option A is incorrect. Most dural arteriovenous fistulas actually drain into a dural sinus and not less than 1%. Endovascular embolization is the mainstay treatment, and option C describes arteriovenous malformation, not dural arteriovenous fistulas. Remember, DAVFs do not have a nidus and neither do they have pia arterial supply. DAVFs are acquired lesions and not congenital, which makes options D to be incorrect. And cortical venous drainage increases the risk of hemorrhage, which makes options E correct. Next question. Question 69. A 62-year-old man presents with acute onset of right hemiparesis and global aphasia. He was last seen normal 1 hour ago. His NIHSS score is 20. CT demonstrates no hemorrhage and intravenous TPA is started. A CTA is then obtained which demonstrates a left MC occlusion in his proximal segment. What is correct regarding endovascular thrombectomy for this patient? A. Endovascular thrombectomy is contraindicated after intravenous TPA. B. Endovascular thrombectomy is indicated and associated with better clinical outcomes. C. Waiting period is indicated to determine if there is improvement with intravenous TPA. D. Endovascular thrombectomy has not been proven to benefit clinical outcome. And E. CT perfusion or MR perfusion is mandatory to determine if this patient benefits from endovascular thrombectomy. What do you think? Now let us look at the clinical context and relevance. This patient presents with hyperacute anterior circulation stroke. He has severe neurological deficits, NIHSS score of 20, which suggests a large vessel occlusion. And his imaging, which is a non-contrast CT, exclude hemorrhage, and CTA confirms a left M1 occlusion. The time since last known normal was 1 hour ago, which is within the golden period for both IVTPE and mechanical thrombectomy. So, why is endovascular thrombectomy indicated? This scenario clearly checks every major box for Class 1 Level A recommendation for thrombectomy according to the American Heart Association or American Stroke Association guidelines. The eligibility criteria for mechanical thrombectomy includes 1. Age greater than 18, which our patient clearly is. 2. Pre-stroke modified ranking score of 0 to 1, which we can assume for our patients with no prior disability being mentioned. Disabling stroke with an NIHSS score of more than 6. Our patient has an NIHSS score of 20. Large vessel occlusion, that is the internal carotid artery or M1 segment of MCA, which our patient clearly has. Onset to groin puncture of less than 6 hours. Our patient came in within less than 1 hour. And an aspect score of greater than or equal to 6 on non-contrast CT, which can be seen in our patient who has no large infarct core on CT. There are certain key trial evidence which were the game changers in the management of stroke, and they include the Mr. Clean trial, which was done in 2014, which is the first randomized control trial to show the benefit of thrombectomy, the Escape, Extend 1A, Swift Prime, and Reverse CAT 2015 trial, which confirmed the efficacy in patients with anterior circulation large vessel occlusion within 6 hours windows and minimal infarct core. The result of these trials was 1. Improved 90-day function independence with an MRS score of 0 to 2. Number needed to treat was as low as 2 to 3, and mortality and symptomatic intracranial hemorrhage was not increased. So, back to our question, our answer is option B. Endovascular thrombectomy is indicated and associated with better clinical outcomes. And that's a wrap. Today, we tackled the big stuff: where aneurysms hide, how eye popping fistulas present, which fistulas love to bleed, and when it's time to dive into the artery and save the brain. Whether you are managing your first stroke code or preparing for the bots, remember, early recognition and decisive action can change outcomes. Don't forget to subscribe to NeuroClarity, leave a review, and share this episode with your fellow brain warriors. Until next time, stay sharp, stay curious, stay clear, and keep learning. Bye for now.